Good evening and welcome to UPMC Sports Surgery Clinic Evening for Runners. I'm Fiona Roach. I'm the General Manager here in the Sports Surgery Clinic. For any of you that don't know us, we're about 10 minutes from Dublin Airport in Santry, just off the M50 and the M1. All we do here is musculoskeletal, soft tissue, joint surgery for your knees, your hips, your ankles, your elbows and shoulders. And for those runners, we do ACLs, all ankle injuries and sprains, etc., and knees. So tonight we're actually concentrating with Maurice O'Flaherty talking on the ankle and the foot. And Maurice will be here first, and he'll join us afterwards for a live Q&A. And that will be followed by Colin Griffin, one of our therapists in running. So if you have any questions, there's a tab there for Ask a Question. Please ask a question. I imagine there'll be a lot of questions tonight, so we will endeavour to get to most of them, and some of them we might put together and talk through a few of them with you. So we're going to start now with Maurice O'Flaherty's talk, and Maurice will join us live for a Q&A afterwards. Thank you.
Good evening, everybody. My name is Maurice O'Flaherty. I'm one of the consultants in the Sports Surgery Clinic at UPMC, and I'm here to talk tonight about common runner injuries. So first of all, a little bit about myself. So who am I? Well, I've been a consultant trauma and orthopedic surgeon now for 14 years, and I work mainly in the UPMC and Sports Surgery Clinic in Dublin. I did a master's in sports and exercise medicine in the University of Bath in England. And I myself am a keen runner, try and do about 10K 2 or 3 times a week. And I also enjoy going to the gym. So first thing is, why does it matter? Well, if you're anything like me, this is happy you when you're out running. It's not just good for exercise, but also to clear your head. And also, if you're anything like me, this will be you when you're not running, or when you can't run because you have an injury or there's something going on and you're ready to kill dead things. So between the two things, obviously running does matter. You wouldn't be here this evening. So if we move on, what are the typical runner injuries? Well, I've done my best tonight to not go into any medical severe speak. This is really just to go over the common injuries, and then Colin's going to talk about the rehab and things like that. So the main things I'm looking at and that I see all the time are Achilles tendon injuries, bone stress injuries, plantar fascia problems, and then of course sprained ankles. So why me? Everybody asks, why has it happened to me? What's going on? Why is it me that's hurt my ankle, me that's hurt my Achilles? Well, the answer is that there's many contributing factors. The first one and the commonest one we see is just literally overtraining or doing too many events and too many things going on and just not taking enough time to take a break and give your body time to recuperate. I have a picture of the trainers there because, believe it or not, there is a big difference between some of the trainers out there. As you no doubt know, some of them have zero heel drop like the Ultras. So you put a little bit more stress on the Achilles, a bit less stress on the knee. Other ones like the Hokas have quite a large heel to toe incline. So some of them are 12 millimeters. They've got a big stability sole. And if you're flipping between one and the other and you haven't done it before, that can lead to injury. The other pictures there, if you transition from road running and you've done road running all your life and you've decided to take up fell running, well, again, obviously these have different demands on the body that, can lead to injury if you're not used to them or haven't prepared. So one of the big things that you'll find that I touch on is your gastrocnemius. Your gastrocnemius is attached to your Achilles. And what's the big deal? Well, in a lot of studies in recent times, the gastrocnemius and the Achilles have been interlinked with foot problems and Achilles problems and ankle problems. So they are pretty important, as you'll see. So if we look first at Achilles tendinopathy, what is it and what causes it? Well, you've got the symptoms, mid-substance versus insertional. When do you see me? The first thing is, what is it and what causes it? Well, as you may know, Achilles' mother, Thetis, dipped him in the river Styx to make him invincible. He was dipped by the heel, and obviously that left him vulnerable in the heel. The Achilles itself links the gastrocs and the soleus to the heel bone. It's actually the strongest and the longest tendon in the body and can take up to 10 times body weight when it's under tension. it powers your stride, and every step stretches and contracts it. So it is a very important role when you're running. And you may be saying, this guy's crazy. What's he putting up a picture of spaghetti for? Well, I think this is the easiest way to think of the Achilles tendon. And when we go on to the plantar fascia, if you imagine that the Achilles tendon is made up of lots of lovely stripes of collagen fibers, when you look at it under a microscope, very much like the spaghetti in this picture. And really, we moved away from the idea that it's a tendonitis. It's more of a tendinopathy. And what do I mean by that? Well, it's more wear and tear. So if you looked at it under a microscope, it'd be more like the frayed rope there on the left. So it has a little bit of fraying, just a bit higgledy-piggledy and out of kilter with its normal self. Uh, so what can cause it? Well, tight calves, as we mentioned before, stiff ankles, poor footwear, overtraining and overloading it, all are implicated in it. So the symptoms, you may have already know these yourself if you've had it. Lump in the Achilles that itself is tender. It can be worse when you're getting out of bed in the morning. The reason being that your gastric namus is usually very tight and contracted when you're sleeping, because most people sleep with their knees bent, and then you get up out of bed and stretch everything out in the morning. Pain getting up from rest. If you've got pain down at the heel, it's usually down where it rubs on your footwear. And then in either way, you're usually unable to train as you normally would. So when do you see me? Well, if it's chronic, going on for more than 3 months, if it's not improving with stretches or self-management, or if physiotherapy is not working, then we sort of look at the treatment ladder and we decide where you are going to go next on the next rung of the ladder. So what can I do? Well, as usual, take a good history from you, examine you, usually get an MRI scan if you haven't had one done. There's one of the things that we find very useful, which if you have a lesion like that at the back of the Achilles, is a hydrodilatation. Not everybody's suitable for it, but we'd see if you were. And if you are, then we basically strip off the jacket that encloses the tendon and has some of the nasty sort of blood vessels that grow around it and bring in all the nasty pain chemicals. And we strip these off, and that usually gets you back to a more suitable baseline level where you're not as sore and the physio can work with you again. Excuse me. Achilles lengthening are very useful via gastric nemus release. It's a very small day case that we sometimes do if the calf tightness is the main thing driving it. One of the big things about Achilles and plantar fascia is if you don't get rid of the calf tightness, or you can't, then all the other ways of trying to get you better don't work very well. So they're not as effective. PRP injections, some more evidence for these nowadays, very limited, but there are certain times when they work very well. And then, as ever, surgery is a last resort. So the next thing then, bone stress injuries. What do I mean by that? Well, on the left, you can see one picture. This is your heel at the very bottom. And on the right, you can see the same picture, but it's a bit darker. The one on the left is the abnormal one, and that is the one with the bone stress in it. So the areas of white on the left-hand side should not be present in the bone. And what is that? Well, I try to describe it like a crunchy bar. And if you imagine punching a crunchy bar with your knuckle, the chocolate on the outside will be okay. But if you imagine the honeycomb on the inside is a little bit stoved in and a little bit watery. And why is that? Well, it's essentially a bit like in bone. There's an overuse that can be common in runners. It can be for a variety of reasons, usually trauma or overuse. It can be metabolic due to some of your metabolism and your hormone imbalance or things like that, or it can be due to inflammatory conditions. And what happens in all of them is that fluid accumulates in the soft bone or the cancellous bone. That leads to pain, swelling, and it often worsens with activity. And quite often people come in with a limp, things like that. What do I do? Well, we very importantly offload the area that's injured. Quite often, this will require 6 weeks in a walker boot, one of those moon boot you see people walking around in. This usually settles down the acute phase, and in that time, we also check your vitamin D levels, which unfortunately in Ireland we're very low in, obviously with very little sunlight. And we also check your thyroid function test, as that can sometimes be a bit off as well. If we're concerned about your bone density, we'll get a DEXA scan, and sometimes we get a post-injury MRI, but more than usual, we actually find that you're settled down with your time in the boot. And if we've checked all the other things, the more important thing can be to check your biomechanics, your running pattern, and get an orthotic if need be. So moving on, plantar fascia is the next thing. What does the plantar fascia do? Well, the plantar fascia is, believe it or not, very important. It is a shock absorber mainly in the heel, and it transfers force across from the heel to the balls of the toes. And this is made up again of type 1 collagen. And again, I go back to the original picture, we're thinking of spaghetti. So under the microscope, lovely and straight fibers, very uniform. And when you look at a plantar fasciopathy, again, not fasciitis because there's no real true inflammation involved, you see that it looks like the rope on the left and a bit frayed. This too is why anti-inflammatories don't tend to work with plantar fasciitis or Achilles tendinopathy because it isn't true inflammation. So what can cause it? Well, this is one where tight calf muscles are implicated quite a lot. It's very important to assess the tightness in the calves. This is the number one thing that should be tackled before doing anything else for plantar fascia issues. Um, Usually comes on as a result of overuse or activity. If you've got a high BMI and overweight, then you're more likely to develop it. Occupations where you're standing for long periods of time in hard footwear or on hard floors can cause it. A bit less so, your foot biomechanics can be a bit off, or poor footwear can cause it. And the good news is that in the majority of cases, 80% of the time, physiotherapy will settle it down. If that doesn't work, then that's when I tend to see you again. Things we can do, calf releases for a tight calf. Shockwave therapy works very well in cases where physiotherapy hasn't worked well. We don't tend to inject plantar fasciopathy. I certainly don't recommend steroid injection. All the evidence shows that it just gives a short time fix and then it comes back again. And you add to that the risk of rupturing the plantar fascia, so I don't do it. However, there's a bit more evidence for PRP injections, again, in limited cases and depending on MRI appearance, but that's something we sometimes consider. Finally, if you've got to the top of the ladder that we discussed before and you haven't got better, then one of the operations I can do is a keyhole plantar fascia release, done as a day case, very, very tiny scars on either side of your heel, and you get going within a couple of weeks and it tends to work very well. But obviously, again, it's a last resort. Moving on then to ankle sprains. So what do we mean by an ankle sprain? Well, the majority of runners are going to be concerned with a lateral ankle sprain. A high ankle sprain is another type, but in runners, this isn't seen too often. There you can see the lateral ligaments on the left with the ATFL, CFL, and PTFL. And then on the right-hand side, you can see the syndesmosis ligaments. So syndesmosis injuries are also known as high ankle sprains, difficult to recognize unless you have a physio who's really on it and knows what they're talking about. It's very uncommon in runners, so we'll only touch on it. And it's usually only about 0.5% of the ankle sprains seen. Excuse me. Much more commonly then, we have our lateral ankle ligaments that are injured. So you see here clearly ATFL and CFL. PTFL nearly always is intact because in the majority of cases when you roll your ankle, your foot's pointing down, and so ATFL and CFL are in tension, and PTFL tends to be lax, so therefore it's not injured as often. So what happens? Well, with an inversion injury or rolling your ankle, a lot of people sometimes hear pop or crack at the same time. You're immediately unable to play on or run on. You get severe pain and swelling, and then bruising develops shortly after. People talk about hobbling about for a few days. Many of you will go to your local A&E department and will have an x-ray taken and be told there's no fracture, sure on you go. If you're very lucky, you'll get a boot and then you'll see your physio. Sometimes you'll have had an MRI, and usually then when you're not getting better, you'll be sent to see one of us. So what does the MRI tell us? Well, it usually informs me about the lateral ligaments, so the ATFL and CFL. As I said before, PTFL is usually fine. You'll have a synovitis, and this is just a reaction of the capsule around the joint with a lot of inflammation going on. And you'll see sometimes bone edema in the talus, as we touched on before. The bone edema is just bone bruising. And that means whenever you roll your ankle, sometimes the bones hit together very quickly for a short period of time, and then it goes back to the normal position. And that leaves a bit of bone bruising in the bone that itself can be a pain generator. Finally, you look at syndesmosis in the deltoid ligament, but in the running injury, unlikely to have hurt those. So who is this? Well, some of you might recognize Tony Finau. Back in 2018, he was doing the par three competition at the Masters, and he got a hole in one on the seventh hole, ran off to celebrate, and then rolled his ankle. I mean, on the left there, you can see a severe ankle sprain. So it can be a significant injury. And with regards to lateral ankle sprains, as I say, physios are wizards. So majority of ankle sprains like this, functional rehabilitation is the key. We don't just keep the ankle straight and doing nothing. It's very important to get it moving in specific ways, and that's what the physiotherapists are amazing at. Usually referred to me if it's unstable despite physio, you've got ongoing pain, or you're a high level sports person trying to get back sooner. And in the majority of cases, any surgery or anything that needs done can wait or be managed up until the time is right. So what do I do? Well, one of our best operations that we do is a lateral ligament surgical reconstruction, and it involves two parts. One is looking inside the ankle and clearing out any scar tissue. That's the ankle arthroscopy or keyhole bit. And then the other bit is the lateral ligament stabilization, which is reconstructing those ligaments again and trying to make them tight. And on a first go, it's generally a winner operation, can be done in the off period of your sport or your activities. Usually done as a day case, you're in and out the same day, general anesthetic, and it takes about an hour to do. And you're a couple of small cuts, and they're reconstructed with special suture anchors that we have. The recovery is fairly quick. So days 1 to 10 is just getting over the operation itself and letting the wound start to heal. From week 2, we get you out of the cast and into a walker boot and get you fully weight bearing in the boot and start specific ankle movement exercises. About week 6, we increase those exercises and aiming towards a return to some sort of sport by month 3. Again, the physiotherapists are all instrumental in the recovery. And in conclusion, then, communication between the physiotherapist and radiologist in any of these issues is key, and they talk to us. All of these are best managed in high volume centres like the UPMC Sports Surgery Clinic. You want to be going somewhere where they see these things all the time. As you probably know, you have stories of people being coddled along for months and not really getting anything done. And it is important, if you think something's not right, just to come and get checked out. Runners' injuries in particular are varied in presentation, and the clinical picture really guides what imaging we request and when we request it. And the images we get then helps the surgeon choice as to what we do. And that's really it. And that's all I wanted to say this evening. If you have any questions, just remember the answer is always that it's science. Thanks very much.
Thank you, Maurice. Really interesting talk, and we have a few questions coming in. So I'll start with the first one is, which will come up probably a few times with people, is do you recommend a brand of shoe for good support for running?
Thanks, Fiona. So I hope that talk was of use to some people. So asking you for your favorite shoe for running is a bit like asking you what your favorite type of car is. Everybody will have their own answer. I suppose it depends really a lot on what you're trying looking to do recreational running. Some people are looking to do longer runs like half marathons, marathons. I suppose the commonest type of trainers out there that we see all the time are Hokas. A lot of people like Hoka trainers. They're very good cushioning. They have a good heel to toe. It makes it easier to run in. The heel to toe is 12 millimeters or so. It's quite high. So some people who have knee problems and who like to do a bit more like barefoot running, well, that's when I was talking about the ultras in my talk, because they actually are zero heel drop. They have a wide toe box. They can be plush as well, and they can help people sometimes who have pains in their knees running. So you've also got Brooks, you've got the gel, the Nimbus gel, the ASICS ones, which are very good for distance. If people are doing tempo runs, they sometimes use the Hoka Mach 3 or Mach 2, the sort of the lighter trainer. So really, there's a vast majority out there that can help people. I think the best thing to do is to go to somewhere in your local town or city that is a proper running shop, not just a trainer shop, but a proper running shop. And they'll give you lots of advice. For example, in Dublin here, there's Run Logic, and it's run by a guy called Ash, and they give very good advice, and you can try the trainers on. Some of them will even have a treadmill you can run on and be filmed on, and they can look at your pronation, your supination. There's lots of different tweaks to all the trainers nowadays. They've some of them a medial guide, which means that they'll help you if you're a pronator, and there's others that can go the other way. So it's really individualized now compared to the days of just sticking on a pair of Nike Pegasus and running as far as you can.
Yeah, lovely, thank you. When is it time to see a foot and ankle specialist after numerous sprains? And when is it that you kind of decide that the physio isn't working?
So this is probably the commonest thing we see. As I said in my talk, there'll be quite a lot of times where patients have a history of going over on their ankle or they roll their ankle. And the common history is if you've done it once and you do it again, quite often it'll swell up almost immediately, because what happens is the sort of inflammatory cells that go along with that incident then are already there in your ankle, and they're ready to kick off again very quickly. But also the swelling goes down quite quickly again after a few days, and people get going again, to the point that then they probably forget about it and get back to running or whatever they're doing. Some people have had physiotherapy, and usually, as I said in the talk, that works very well. I think probably when I should see it is if you're running and you feel like you're going to go over on it all the time, or if you're doing simple things day to day, like walking on a cobbled street, taking the bins out at night time, and you feel you're rolling over on your ankle, well, then that's another indication that you can do all the physio in the world you want to, but it's not really going to help that problem. So we'd really like to see those patients come to see us, because it is a very good operation to sort that out for you if it's got to the stage where physio alone isn't working, and we can really stabilize that and get people back to a good degree of sport again.
Okay, good, thank you. I'm 74. I've always kept fit, ran for years, now do a lot of fast skiing, Pilates. Is that sufficient exercise? Person walks 10,000 to 15,000 steps, but has a meniscus surgery a year ago. Is it too much walking?
Good man. If I'm doing that when I'm that age, I'll be delighted.
Yeah.
Yeah, I mean, you can never do too much walking in reality. I suppose the thing again is in moderation. The Pilates is very good just for non-impact stuff. I suppose the sore your ankles get, or the more your ankles get unstable, or you feel like you're really having trouble with your ankles, then I often say to patients to switch from the impact stuff, which unfortunately is running, over to
Yeah.
non-impact. So bike, cross trainer, rowing machine, things like that. But again, walking isn't really true impact in that sense, in that if you're walking on a fairly flat surface and you're not testing the ankles too much, it should be fine. The walking that's a bit more troublesome then can be the hiking or unstable paths, things like that, or sand even, believe it or not. So you have to obviously tailor it to that.
Yeah, okay, thanks. Would you recommend anything in particular for prevention of plantar fasciopathy in police officers? Great presentation, thank you.
Well, yeah, I mean, they've just given the name away. So it used to be called Policeman's Heel.
Yeah.
The reason being it was all policemen and policewomen got it. It's really all about, and I sort of touched on it, you can't touch on everything in the talk in great detail, but from looking at, if you look at the literature over the last 5 to 10 years, plantar fasciopathy, a lot of it is the breakthrough, and is the fact that it's not an inflammation thing. It's not an itis, it's a fasciopathy. And that then stems from the fact that the calf muscle is very integral to it. So even though they're not technically connected, the calf and the Achilles down over the heel and then into the plantar fascia really works as one big unit. So if you can keep the plantar fascia stretched out, i.e., by stretching the calf and the hamstrings, then that is the majority of the issue solved. You may need a bit of tinkering then with all the other stuff, but the calf tightness is the number one thing to get rid of initially.
Okay. I had a small tear, lateral tear tendinopathy of Achilles insertional like PRP, which cleared the tear, but still experiencing some pain. Is this common? What should I do next?
Yeah, so it's good to mention PRP again. The
Yeah.
PRP, it was a bit dubious as to whether it helps for everything. It probably doesn't help for everything yet, and there's other stuff we don't know it'll help for yet. It's still being looked at. It's early days. But the thing I find it very useful for is, like in my talk when I was talking about the rope being frayed, or that's called like an interstitial tear. So in other words, they're little tears that are present in the tendon. Excuse me. So PRP into that does definitely help both in the plantar fascia and in the Achilles tendon. If you're having trouble still, well then usually that's then a time to see one of us, because Quite often, the MRI will show up things like calcium in the tendon where it inserts into the heel bone. The heel bone itself might have a slightly abnormal anatomy, which makes you more prone to it, a thing called a Haglund's deformity. And again, that can be the thing that irritates the tendon, or it could be the thing that's in between the two of them, which is the thing between the tendon and the heel bone is a wee thing called a bursa. And that's just a fluid-filled sac. They're all over the body. They prevent friction. But the one in your heel is particularly prone to getting inflamed, to getting angry. And it could be something like that as well. So there's quite a lot of anatomy around that one part of your foot that needs taken into consideration to decide what to do next.
Okay, thank you. I have a narrow gap in my big toe joint leading to a lot of friction and pain, like steroid injection. It's given me short-term relief before the pain returns. I wear runners with a rocker. Any advice on pain prevention?
Yeah, so I mean, if you're getting steroid injection into your big toe and you're aware that the joint is a bit smaller than it used to be, then it sounds to me like you have a thing called hallux rigidus. And we grade it from 1 to 4, with 1 being not too bad at all, 4 being the worst. And believe it or not, MRI is good, but X-ray is actually the best, the standing weight-bearing X-ray, which you can get when you come to see us, and we get certain views. And that really determines what you can do, because after a while, no matter how many injections you put into it, it won't help. The rocker sole in the trainer is a bit like the old-fashioned insoles that you used to get for it, which was called a Morton's blocking splint, and it basically stops your big toe from dorsiflexing up, and that's just really for pain relief. But I would say if you're having symptoms like that in your big toe, the earlier we can see you in terms of looking at the degradation of the joint, the better, because really, you go from 0 to 60 very quickly with toe arthritis, and you either have nothing done or you can end up with needing a fusion done, which makes it a bit harder to run. But there is an in-between operation called a kylectomy, which if you're like a grade 2, 3, or if you're in certain conditions, if the x-rays prove that they can do it, then it works very well, and it maintains the movement in your big toe, which is a big thing if you're a runner. So I would encourage you to be seen early if you've had a couple of x-ray guided injections into the toe and you're still sore. It's probably time to come and see one of us, just to make sure you don't go too far, because you might be able to keep the movement and it might help you.
Okay, thanks, Maurice. We'll just get 1 or 2 more in, and then I prefer to run over grassy areas in country parks, mountain, wear ankle supports. Is running on concrete areas more likely to do damage to your joints?
The concrete will give you a bit more impact, force through the ankle, force through the feet. But conversely, it's actually probably worse for your ankle running on grass or on sand. It's sort of an urban myth that you're better not running on flat concrete, because if you imagine the stabilizers of your ankle are on both the outside of the ankle and the inside, and it's different muscle groups and tendons that do that. But there's also ligaments involved, which is like the lateral ligaments I was talking about in my talk, and the inside ligaments. So those ligaments all don't like very much being on uneven ground, because there's constant adjustment to the undulations in the ground. And actually, it's much less stress on your ankle or your foot to be running on flat floor.
So I was going to say, you mentioned collagen a few times in your talk. And any thoughts on supplements for collagen? And does menopause impact?
So yes and yes. So collagen supplements, yes. I mean, there's plenty of information out there on them. The marine collagen's probably the one with the best evidence behind it at the minute. But then you also have the nutritionists who say that if you have a good protein in your diet, there's really no need for collagen supplementation. So as long as you're getting your 30 to 60 grams of protein a day, you shouldn't really need collagen peptide supplementation. What was the second bit of your question?
Menopause.
Sorry. Oh, the menopause. Yeah, I mean, yeah, unfortunately, yeah, that does affect the tendons, affects the ligaments. It also affects bone density. So it's quite a common one for the bone stress injuries, is the hormonal imbalance that sometimes comes with the menopause. So yeah, that's another thing that we look at when we see you looking in the whole round of things.
Yeah. This will be the last one now. Someone they get a sort of kind of burning feeling between the Achilles and the ankle bone. Is it tendonitis or something else? Planning on running a marathon in Dublin in a few weeks.
Yeah, it sounds suspiciously like Achilles tendinopathy at the insertion. So where
Yeah.
the Achilles inserts into the heel bone, that would be probably the top likelihood of it. You could try doing a bit of stretching and hope that it goes away, the calf stretches. But again, unfortunately, that person might be predisposed to having a bit of Achilles tendinopathy at that part where the Achilles inserts.
Yeah.
So fingers crossed for them.
Maurice, thanks very much for joining us
No,
tonight.
thank you for having me. Thank you.
Welcome. And our next speaker now is Colin Griffin, and Colin will join us as well after his talk for a live Q&A. Thank you.
Thank you, Fiona, and good evening, everybody, and looking forward to presenting to you this evening on, I suppose my title is Building Running Robustness, given that there's a running injury theme to this, and maybe discussing some things you can do to minimize the risk of injury and to help to make yourselves more robust as runners, either yourselves if you're athletes or as coaches with your athletes. So basic outline of the webinar is we'll go through some of injury risk factors and overuse injury models, or what we think we know of how these overuse injuries occur, because most running injuries are overuse injuries. You can get the odd acute injury. We'll discuss some of the common running injuries and what we know about them. I'm going to give an overview of the biomechanical demands of running and discuss then strategies to build robustness and to prevent or minimize the risk of developing an injury. So I suppose the first thing to consider is that our bodies are designed to adapt. Every system in the body, whether it's our energy system, whether it's our hormonal system, nervous system, muscle tissue, and anything else, is designed to adapt. And there's a very old and a model that's kind of stood the test of time called the General Adaptation Syndrome by Hans Selye, a Hungarian sports scientist. And this applies to any sort of aspect of biology. And we've got a baseline. That could be a baseline level of fitness. That could be your tissue, whether it's muscle tissue, bone tissue, tendon tissue, or cartilage. And we've got the baseline. And if we want to change the baseline, we've got to give it some stress. So when we train, we apply stress to the body. And as that stress is applied, our baseline will temporarily drop because our system is fatigued, it's under stress, alarms go off, hence it's called the alarm phase. And once we give ourselves enough recovery time, we get a chance to recover, and our fitness level or our capacity will increase. So it is important to have that sufficient recovery time. And that recovery time, that window is known as a resistance phase. So we're starting to become resistant to that stress that's applied. And our capacity goes up, it's called supercompensation, and we reach a new baseline level of fitness or tissue capacity and so on. However, if we don't adapt adequately or sufficiently, whether that's because we overload, the stress is too much at a moment in time, we haven't had enough time to recover, and we're operating at a low level of capacity on that given day or week, or haven't factored in the accumulated load and fatigue over the preceding days or weeks and so on, we don't adapt, and the alarm phase, I suppose, extends a little bit further, and our ability to recover becomes compromised and takes that a little bit longer. And if we don't allow for that an adequate window and try to apply more load on while recovery hasn't been fully complete, then we're at risk of some sort of performance decrement or risk of injury or illness or some sort of negative adaptation. So this paper by Tim Gabbett was published early this year, and just a nice illustration of how we can apply that general adaptation syndrome model to tissue. And he's, I suppose, taken some of the best evidence that we know for different tissues like cartilage, bone, tendon, and muscle. And you'll see that there are different, depends on the stress applied, obviously, you'll see that there are different recovery windows for each tissue. So for cartilage, when we apply repetitive sort of impact loading, cartilage can recover quite quickly within 30 minutes after a loading bout. That could be hopping, that could be landing, something that's kind of short and intense. Obviously, the accumulated running is a little bit different, but cartilage is designed, it's compressible and deformable. It is designed to repair itself and recover in normal circumstances. Obviously, cartilage does break down over time, and as athletes and even non-athletes get older, other factors such as metabolic factors, inflammatory factors can impact the cartilage's ability to recover and adapt. And bone can also recover quite quickly after short bouts of high intensity loading. So doing something like hopping or skipping or even sprinting, the bone tissue can recover within 48 hours. Obviously, during extended running periods, that can take a lot longer. Tendon, normally when we apply high intensity loading to a tendon, whether it's like plyometric exercises or sprinting or something of high intensity nature, it does take 48 hours or so to recover properly. And then if we apply high intensity loading to a muscle, particularly fast eccentric contraction, so eccentric is when the muscle fibers lengthen under tension, that does take, you get DOMS afterwards if you're not accustomed to it, and that can take up to 2 hours or more to recover. So again, it's important to keep that in mind. Different tissues take different time frames to recover and adapt. So essentially, when an injury happens, that tissue fails to adapt for some reason. And usually there's a mismatch between load applied to the tissue and the tissue's capacity to handle and adapt to that load. And I suppose load and capacity can mean different things. So again, this is quite a busy flow chart, but if we just work through it, on the left, we've got capacity. And if you look in the top left, that's your tissue capacity at the start of a training session or a given week. And that can be influenced by your previous training, how many years of training you have behind you, or even that given season, how many weeks of good, solid, consistent training you have behind you, your previous injury history, your diet, your sleep, your genetic factors, and the time between training sessions, or whether you've recovered adequately between your previous high intensity or high volume or high load training session. And when we're fatigued, you know, that our tissue capacity can temporarily reduce if we do a hard session, or if we accumulate a number of high demanding sessions over a period of time, that tissue capacity can reduce temporarily. And on the right hand side, if you look at load, there's different, I suppose, factors involved here. There's a load per stride, that's the force going through the body, and at an internal level, the force going through the tissue. And that can be influenced by speed, duration, and also the terrain you're running on, whether it's hilly ground, flat ground, and uneven surfaces versus solid surfaces. And then there's a load distribution per stride, because when we, you know, put load through the body, you know, different tissues can experience different stresses, and that can vary from person to person. So someone's anatomy and body shape can differ from someone else, and that can influence where that load goes. Someone's running mechanics and style can also impact where the load goes throughout the body. Also running shoes, you know, different running shoes, different shoe types can have different impacts on different people. You know, whether it's your kind of heavy or more foamy type shoes versus your more minimalist type shoes, and also surface. So soft surfaces can vary where the load goes. Hard surfaces maybe less so. But again, not that one surface is good or bad. It's what you're accustomed to. And if you change footwear or change your habitual running surfaces, and you try to do the same training load, that can, I suppose, change how the stress is applied to the body, and that can be a bit of a risk factor if you're in a fatigue state doing that. And then I suppose when we look at that load, how it adds up, the number of strides in a given session, and also the tissue load per stride, and then how that accumulates over the session or over the week or training cycle. And essentially, when we're in a fatigue state, if we go back on the left, our capacity is lower, and we have a high cumulative load built up, and the tissue capacity is exceeded, and then we're at a high risk of a running injury. And I suppose we've also got to factor in the non-training stressors, because it's one thing, you know, stressing the body and recovering properly, but also other non-training stressors can impact the body's capacity or the tissue's capacity at a moment in time. So if we take a typical day for a typical athlete, and you know, if we assume that you dedicate 2 hours to your training in a day, you work or study for 8 hours, you might have a 1 hour round trip commute to work or to university or to school if you're a younger athlete. You might have some social activities, or if you're a parent like myself, you might have your kids' activities in the evening that could take up to 2 hours. You might sleep for 6 to 8 hours, and then you might have 3 hours there to play with for free time. So I guess, you know, we think about the training time, but we often don't factor in the other stressors, the other time, the other 22 hours in the day. And that could have an impact on how you are able to recover and adapt to a training stress or a training stimulus on a given day or a given week. So if your work is stressful, or if you're a student coming up to exam time, that's an extra stress in the body that can temporarily reduce your capacity to handle training, delay your recovery time, and if you don't allow for that in your training, that can predispose you to injury. If you get poor quality sleep, so it's not so much how long you sleep, but it's the quality of that sleep. If you're lying in bed for 10 hours, but you only get about 4 hours of quality sleep, that's not great. Whereas if you go to bed for 6 or 7 hours, and you know 6 hours of that is good quality sleep, well, that's good. So again, most people probably need on average 6 to 8 or even 9 hours of sleep, but the quality of that sleep is quite important. And also how you manage stress, whether it's you know stress in the work environment, stress in your education environment, stress at home, and other things that can also elevate your injury risk. if it's not managed carefully. So most systematic reviews looking at common distance running injuries have pretty much similar findings, and this is one by Peter Francis back in 2018. And the first image here looks at the site of injuries, and you'll see on there that the knee is the most common site of injury. Again, you can have different injury on the knee. Most common is patellofemoral pain syndrome, which is injury to the patellofemoral joint, but you can also have other knee pathologies such as IT band syndrome, patellotendinopathy, a meniscal tear, and so on. Other injuries are at the shank area, which is like your shin area and calf. So that could be like medial tibial stress syndrome. Often referred to as shin splints, which is a bit of an umbrella term, not one I like to use, but anyway, that's neither here nor there. Or even calf injuries and Achilles injuries. And then your foot and ankle area, you know, ankle sprains, plantar fasciitis or plantar fasciopathy, metatarsal stress fractures, other bony stress fractures of the foot. And again, some of these are broken down. So again, patellofemoral pain syndrome is the most common injury diagnosed from this review. Achilles tendinopathy comes in second. Medial tibial stress syndrome, plantar fasciitis, iliotibial band syndrome, and so on. Calf strains, meniscal injuries, stress fractures. But the main thing from this is that 2/3 of running injuries occur from the knee down. So there's probably a message in that. And if we do a basic needs analysis for running, you know, because when you look at most strength training programs and advice for running, people focus a lot on the glutes, the core, and all the rest, and probably neglect the muscles lower down that are probably quite important. And one study done in 2012 using musculoskeletal modeling determined that at around steady state running speed, which is around lactate threshold pace for most people, the calf muscles, the gastrocnemius muscles and the soleus, are the biggest force producers. They produce forces of around 8 times body weight, so quite large. Next in line are the quads, and then the hamstrings, the glutes, and the hip flexors. So the calf muscles are the big players when we're running, or even when we're jogging. And if you look at some of the chronic running injury sites, particularly the joints and around the knee and the lower limb area, if you take the external ground reaction force going through the body, when we're jogging, that's around twice body weight. When we're running slow to steady, that's around 4 times body weight. When someone's sprinting, that's about 6 times body weight. That's the external force going through the body. And if you look at the ankle, the contact force at the ankle joint, so think of that like almost like a suction pump at the ankle. So that kind of bone-on-bone contact, which is cushioned by cartilage and synovial lining around the bones and the articular surfaces, that's around 10 to 14 times body weight. And the force going through the Achilles tendon as it stretches is about 6 to 8 times body weight at kind of typical steady state running speeds. The knee joint contact force is around 7 to 11 times body weight, and the hip joint contact force are 7 to 11 times body weight as well. So a lot of forces, a lot of stress going to those common injury areas. And I suppose the question is, how are we prepared to handle those stresses over and over again? And if we look at some of the common running gait features associated with running injuries, this study by Chris Bramah in University of Salford in Manchester took a cohort of runners who had different lower limb injuries and look at some of the common features compared to those who were not injured. And you see on the left in a side view, you see someone who overstrides, so lands a little bit more on the rear foot, and the shin angle is a bit more negative or angled, and the foot is a little bit further in front of the body and a slight forwarding compared to the image B, where someone lands slightly more midfoot, more of a vertical shin, the foot a little bit closer to the body, and a more upright torso. And then if you look at rear view, on the far right, you'll see in image A, the athlete has what we call a contralateral pelvic drop. So when the right leg is supporting them, their left hip or pelvis drops or tilts a little bit. You'll see the right knee twisting in, and you'll see a lot more rotation. You can see more of the toes on the foot from behind. So a lot more rotational forces going through the body there. Compared to the athlete in image B, who has a more horizontal pelvic line, has a less twisted in looking knee or thigh. And if you look from their ankle up to their hip, it's a lot more vertical compared to the athlete on the left in A, who's got a lot more where the knee sits a little bit more deviated in medially from their ankle and their hip. Now, there are people who run with some of those negative features who don't get injured. So, you know, biomechanics is one thing, strength is another thing as well. But the key thing here is you look at all relevant factors that might load the body and also influence the body's capacity to handle that load. And for athletes who are more at risk, we try and influence those factors. As I said, if someone is a world-class runner, looks like at least in A in both those images, and they're not injured, they're operating at a high level, you mightn't change those mechanics too much because that might come at risks. Because if we change someone's mechanics, we're shifting load from one structure to somewhere else. So again, there's got to be good logic to do that. If someone has a recurrent injuries, they run with those mechanics and those loading patterns are relevant to the injury, obviously then we will try and influence that. So again, it's a little bit of common sense and logic. So again, some of these features that are seen are associated with patellofemoral pain syndrome, medial tibial stress syndrome, Achilles tendinopathy, and IT band syndrome. And a follow-up study in a different cohort of athletes found similar running features with people who've had previous calf muscle strain injuries. So if we kind of look at the calf muscle, which I've kind of emphasized quite a lot, and again, I don't want to overplay one muscle group in particular, but they are for long distance runners, they're actually quite they're quite relevant muscles, and they're quite big muscles as well. So for most people, you know, if you look at some from behind, you'll see the superficial calf muscles, which is the lateral gastric muscles, muscle head, the LG as illustrated on that image, and the medial gastrocnemius muscles, MG. And then the deeper muscles, which is not very visible, is the soleus muscle, which is the biggest of the three muscles. So your calf muscles comprise of three muscles. Those three muscles fuse to form the Achilles tendon. And as I said, that the most dominant lower limb muscles are during slow to moderate speed running. And at around lactic threshold pace, which is like marathon speed or upper end of someone's zone 2, they operate around 85% of their maximal force capacity, whereas the quads might operate at around 65% of their maximal force capacity at that speed, and maybe the glutes and the hamstrings and quads, or sorry, glutes and hamstrings and hip flexors might operate more at 40 to 50% of the maximal capacity. And obviously those lateral muscles, those glutes and hamstrings and hip flexors, their force output will increase quite exponentially at sprinting speed. But at jogging speeds, they're operating at a lower capacity of their maximal force. And those calf muscles are packed with a lot more short fibers, mainly slow twitch, which enables high force output and efficiency. So a lot of force is spread across a lot of fibers, and they're not designed to contract fast or to lengthen and shorten that much. So they can be quite efficient. They're slow twitch, so they can recover very quickly in a normal healthy muscle. But it's also important that the calf muscles has got a good Achilles tendon so that it enables the muscles to contract efficiently. So if we go through some of our common injuries, and Achilles tendinopathy, I suppose, is probably the second most common reported injury among distance runners. And if we look at the image on the left, a healthy tendon has got that sort of very organized collagen structure. So you've got collagen molecules that make up collagen fibrils. Collagen fibrils make up collagen fibers. Bundles of fibers are called fascicles, and then the tendon is made up of bundles of fascicles. In between those collagen fibers, you've got cells called tenocytes, which help to regulate the tendon's homeostasis. So it allows it to maintain its properties and enables it to adapt, or when the load is too much or hasn't got the ability to adapt to that load, those tenocytes can become overactive and cause the tendon tissue to break down. So you see an example at the bottom of a tendinopathy where you've got a less organized collagen structure. You've got a bigger population of those tenocyte cells. They lose their shape. They become a lot more rounded as opposed to kind of more spindle shape. You get a lot more blood vessels and sprouting of nerve endings into the core of the tendon, which don't normally reside there in a healthy tendon. They normally lie in the periphery. So you see an example on the right of an ultrasound image of someone with a tendinopathy. The top of the image, I'm not sure if you can see my cursor, that's the skin side. The bottom of it is the top of your Kager's fat pad, which is like a triangle between your heel bone and your calf muscles. And where my cursor is, if you can see it, that's the bottom of your soleus muscle. So that area there is your mid portion. That's the most common site of Achilles tendinopathy. Yes, you can get a tendinopathy at the heel insertion, but what you see is a kind of a swelling of the tendon. So a normal tendon has about 4 millimeters of thickness when you look at it side on. But a pathological tendon with a tendinopathy, that can actually double or even treble in some cases. So this example here actually has a thickness of 12 millimeters. Normal healthy tissue has like gray sort of strands that are quite continuous or look continuous. And then you see the tendinopathic region has kind of a dark area where you've got breakdown in collagen fibers. You've got an increase in accumulation of water molecules. So the best way to describe this is like a healthy tendon looks like a packet of dry spaghetti. And with a tendinopathy, it's like having a packet of dry spaghetti with a wet patch in it where those spaghetti strands become more thick and kind of gooey and puffy. So that's probably the best way to describe analogy to use for a tendinopathy. So you get a breakdown in collagen structure in that region, extra water molecules. That region is less tolerable to load going through it. And when you have a tendinopathy, it can impact how the calf muscles, their structure and the function of the calf muscles. So you can, the calf muscles the fibers can shorten. That even one head of the calf muscles, oftentimes with a tendinopathy, it can be the lateral gastrocnemius muscle can shrink and can waste. And the fibers from the tendon fibers from that muscle can detension. And that can alter, I suppose, how the calf muscles are loaded, and that can predispose an athlete to recurrent injuries or even a subsequent calf strain. But I suppose there's more things than training that influence the tendon health. So obviously someone's muscle strength and capacity is quite important. So again, how the muscle and tendon muscles, so the three muscles and the tendon coordinate, the mechanical properties of the tendon, how elastic or not elastic they are, and the capacity of the calf muscles. So that's important for tendon health. Training load and physical activity levels. Tendons like routine. So when the load applied or the increasing load is too much for the tendon to adapt to in a moment in time, again, it can trigger a negative reaction from the cells and cause collagen tissue to break down and for a tendinopathy to occur. And then age, obviously older people can reduce some of their tendon properties can reduce. Certain medications like certain antibiotics, steroids, statins can influence tendon health in a negative way. Biopsychosocial factors. So, when you got a sore tendon and you're stressed and you're worried about it, that can amplify the pain response. And especially if you've got kinesiophobia, you're afraid to do something in case it makes it worse. And other systemic health conditions such as metabolic disorders, if you're predisposed to diabetes or other metabolic disorders. For females, hormonal fluctuations, menstrual cycle can impact tendon health. And certain autoimmune conditions like rheumatoid arthritis or other, I suppose, arthropathy conditions can also impact tendon health because it can trigger or fuel an irregular inflammatory response that can predispose someone to a tendinopathy or slow down the tendon's ability to recover and adapt. Calf strains are quite common as well. Oftentimes there's a gradual onset, especially in distance running. So sometimes you can get that sort of that kind of quick, kind of feeling like a dagger going through the calf. So your more superficial calf strains, like the bottom of the medial gastroc, that can feel that can be a sudden onset. You can feel it there and then. Sometimes with a soleus strain, it can be a gradual onset. You wake up the following day and you feel like you got a tight calf, and after I'll just warm it up and stretch it and foam roll it and hope for the best. Doesn't often work like that. So I'm always a little bit caged when someone comes in and say they got a tight calf and it's been going on for a few days, and the point where they're struggling to run, you can't just work that out. So yeah, I would be kind of suspicious of a calf strain, and I would definitely try and get an MRI scan, especially for the soleus, because you won't pick it up on ultrasound easily. Even the most skilled sonographer, you can't fully rule out a soleus strain with ultrasound. So whereas you can with a medial gastroc strain. So an MRI scan is the recommended go-to to properly diagnose a calf strain, especially those deeper muscles. So older athletes are a bit more predisposed. Those who have had a previous lower limb injury, such as a previous calf strain, a previous Achilles tendinopathy, or a previous ankle strain, can have a higher risk of a calf strain or a recurrent calf strain. So if you develop a tight calf and it's gone on for a few days, I would assume it's a strain until proven otherwise by an MRI scan, because otherwise those days can become weeks and those weeks become months, and you're in the vicious cycle of trying to train, breaking down again, trying to train again, breaking down again, and lacking that bit of consistency. Some bone stress injuries. So again, I suppose bone stress injuries are kind of operate along a spectrum. So you can have like say for the medial tibia, you can have like a reaction or an irritation or an inflammatory response around the periosteal area, which is where the muscles sort of anchor to the bone. And it's quite an innervated area where you get you have a lot of sensory nerves, and that can amplify the pain response, even though it mightn't look too bad in an MRI scan, because you got muscles sort of tractioning off that periosteum. Then you can have some bone stress, so the outer layer of the bone that becomes irritated, and you get some bone edema, and I suppose a low grade sort of stress response, not quite a stress fracture, but then you can move up through the grades. Then when you get a proper fracture line, then that's when you're in a lot of trouble. So basically, you got a breakdown of bone tissue, which is a normal response to training, and an inability of that tissue to sort of replenish or to repair itself on demand. And that process could be going on for weeks or months, not necessarily one session. Certain bones have a higher risk and need to be managed very, very carefully compared to other areas. So if you've got a bone stress injury to the medial tibia, you know, again, the prognosis is quite favorable. You know, that there's lower risk if you got a bone stress injury to the fibula or the lateral ankle area. Again, the prognosis is fairly favorable because of the bone's anatomy and geometry. The shaft of the femur, again, the risk is quite low of any complications. The same around the pelvis, same around the calcaneus, and the diaphysis, so a certain region of the 2nd to 4th metatarsals. And the high risk areas are the neck of the femur, the front of the tibia, the medial malleolus or the medial ankle, the talus, which is like in your ankle, that kind of floating bone in the ankle that only doesn't have any muscle attachments, it has ligament attachments, so it doesn't get much blood supply, and the risk of a talus stress fracture that's not managed carefully, you can get avascular necrosis, which is definitely something you don't want to be at risk for. Navicular also can be quite a complicated one as well, and again, there's also a risk of, I suppose, non-fusion of the fracture, and a risk of a necrosis, which is like a dying of the cells, and also certain regions of the 5th metatarsal, and the base of the 2nd metatarsal, and the sesamoids of the big toe. Again, they're got to be managed carefully if you have a diagnosis of a stress fracture in those areas. And certain factors that impact how load is applied to the bones is biomechanical factors, so ground reaction forces, your body shape and alignment, your running mechanics, training factors, so the duration, frequency of training sessions, the recovery windows, intensity and speed, your muscle strength and endurance. So again, the muscles around bones act like struts to keep the bone, to kind of control the loading going through the bone, because even though the bone it seems like a hard structure, it is quite pliable. So the bone is trying to bend or deform when there's load going through it, and those muscles help to buffer some of that. So for lacking muscle strength, the bone gets stressed a lot more. So again, the calf muscles, and particularly your tib post and your peroneal muscles, are quite important for the tibia and fibula respectively. Your foot intrinsic muscles are quite important for, you know, your metatarsals and navicular bone and so on. The training surfaces and terrain, and again, it's not that one surface is good or bad, it's when you try to adapt to a different surfaces while doing the same training load, is an extra stress in the body, and the same comes to footwear. There's no right or wrong shoes that you can sort of apply across the board. Everyone responds differently to the same shoes. But if you change your footwear, don't allow a proper habituation period, and do your normal training, that's an extra stress in the body. The muscles are going to get tired trying to adapt to that, and that can increase bone loading or loading in any other tissue. And other intrinsic factors, you know, that can influence bone's ability to handle load are genetics, diet and nutrition. So especially if you're depleted for long periods of time, the bone metabolism will slow down. Calcium and vitamin D is also important for bone metabolism. Hormonal status is also important, particularly for females, you know, who are of menstruation age. You know, your physical activity history. So again, the more training you have in the bank, and more consistent training you have in the bank, the more robust you are to weather storms and to handle training load. If you have low bone mineral density and risk of, you know, osteoporosis, that's going to be a complication that can influence bone's ability to recover and adapt. And again, certain medications can also weaken the bone and impair its ability to adapt. So some of the common strength assessments we do in the clinic, we'd measure calf peak torque or peak strength, usually on our isokinetic dynamometer, and we would do it at a speed of 30 degrees a second. So you're pushing out with the foot. We also pull back in to work to measure shin strength, but typical strength measures we look for recreational sports person being able to produce torque, peak torque so torque is like rotational force or leverage force, 130% body weight or 1.3 times body weight. For a sub-elite athlete, you know, 1.5 times body weight, and for an elite sports person, somewhere upwards of 170% body weight to twice body weight. Sometimes we might do a seated calf isometric strength test to get a measure of soleus peak force, and again, we're looking for 1.5 to twice body weight of peak force. And also looking at calf endurance. There's one thing measuring peak strength, also calf capacity, so how many reps they can do to failure or to fatigue. So again, on a small 10-degree incline board, being able to do good quality calf raises, and when they get tired, we stop them and count the reps. So minimal 20 reps for recreational sports person, maybe who's of middle to older age, 25 for your average person who's of middle age, maybe plays sport recreationally, and 30 reps for an elite sports person. And sometimes we might delve a little bit deeper, maybe measure EMG, which is like the, I suppose, the electrical activity of a muscle and the ability of the muscle to activate and see what the pattern is between different muscles. And sometimes we also use ultrasound to look at measure muscle architecture. If I see a suspicion of muscle weightage, measure muscle fiber length, and also measure tendon strain as the calf muscle contracts doing calf raises. And so it would profile someone based on this kind of quadrant, where you on the vertical axis is measured with your peak strength, on the isokinetic strength test. So again, the cutoff being 150% body weight. And on the horizontal axis, how many good calf raises they can do through full range, with 25 reps being the cutoff. So if someone's in the bottom left, they're in a poor state, they've got poor endurance, poor force, maybe at a high risk of injury, certainly not doing their performance any favors either. So we want to get them in that top right-hand corner where they've got good force and good endurance. And so we also measure plyometric abilities, the ability to hop and rebound, doing it vertically and horizontally. So an example here of a double leg drop jump. So we measure their contact time and their flight, or their jump height, sorry, on the force plate. To do a double and single leg. In some cases, you might do a horizontal single leg horizontal rebound as well, and maybe measure repeated hops to see what they're like when they're hopping in a more of a cyclical pattern. And we want to see how high they can rebound or jump, or how long they can, if it's horizontal movement, how far they can jump, with a constraint on contact time. So we don't want to spend too long on the ground. So for recreational sports person, we might say under 0.35 of a second, or a third of a second. For a sub-elite sports person, under 0.3 of a second. For an elite sports person, maybe 0.25 of a second. For more of a distance runner, for someone who's more middle distance, maybe under 0.2 of a second or close to it. And we see how high they can jump or how far they can rebound while being under those contact time targets. So to develop calf strength, we would ideally get someone to the point where they can do calf raise on a Sept machine or a leg press. Obviously not everyone can start with that. They might have to maybe start with a dumbbell, or even in some cases, if the baseline is poor or at a low level, start with bodyweight calf raises. But ideally, the calf muscles, they are strong. They're big force producers. If someone can do, single leg calf raises dynamically with good control, working into a little bit of a calf stretch and out of it, get the heels slightly above the level of the block, and maybe to get up to the point where they can do at least half or 60% of their body weight of external load on the Sept machine. And then, for more advanced calf loading, for the more experienced athlete, on a leg press, be able to hold or push twice body weight of external load on the frame. So if it's a horizontal leg press or the plate's slightly above the body, all the load is external. I don't have my own body weight to overcome, so I have to load it up quite a lot. And be able to do repeated 5 to 6 second holds at about twice body weight or even more. And for the tendon to adapt, it needs load, and it also needs strain. So strain is like how much the tendon deforms. So when the calf muscles contract, when I'm doing a calf raise, there's a little bit of a stretch in the tendon, and that sort of stretch activates the cells. And there's a bit of tension and I suppose sliding between the collagen fibers, and that activates the cells and can trigger a positive response if it's done in an appropriate way. And normally a tendon responds positively if the strain is between 4.5% to 6.5%. It can also perhaps adapt positively if the strain is a little bit more than that, up to 9.5%. If it goes beyond that, then and it's done and the tendon is not in a good, I suppose, starting point. If you do a lot of load where the strain is in double digits and the tendon hasn't got good elastic properties and the calf muscles are weak, it can predispose a tendon to injury. And the same if you rest a tendon and don't expose it to sufficient strain, the tendon will just break down and it becomes catabolic, and its threshold lowers. So it takes a lot less for it to get sore or to develop an injury. And I suppose when we're rehabbing an Achilles tendon, a lot of people kind of focus on the calf raises and they're trying to get back running, and then they get injured again, but they haven't exposed themselves to some of the movements that actually replicate the demands of running, like hopping and jumping and so on. So if you look at this table or graph that was done in a study a few years ago, they looked at common sort of calf exercises and hopping and jumping exercises and kind of matched it against the demands of walking and running. So if you look at walking there in the yellow bar, you'll see that it's one thing, I suppose, quantifying the force going through the tendon. The other thing is actually the rate of loading, so that the speed that the force is applied to it. So again, most of your calf exercises, they're important, but they're slow movements. And again, that's fine, but also the tendon also needs to be exposed to fast movements that apply a fast stretch to the tendon. And if you look at running, you're looking at, for a slow run, you're talking of, loading rates of like 60 body weights per second. So if you're just doing calf work, you're only getting about, for a typical calf raise, find one here, single leg calf raise, you're probably talking about 15 body weights per second. So yes, that's important to adapt the tendon, but to prepare for running, it's probably not enough on its own. So when you're doing some hops, especially double leg forward hops, single leg forward hops and drop jumps, you're getting body weights, you're getting loading rates of more than 60 body weights per second. So I always try to expose the tendon to a little bit more than it needs, so it's able to handle the demands of running. So again, typical plyometric training exercises. We might start with doubling poker hops, and just try and get good smooth patterns, aim for a flat foot contact. Most people think they have to land on their toes when they're hopping, but the tendon prefers more of a flat foot contact. It's more favorable way of loading the tendon. And then been exposing it to single leg hops, especially if you want to get back running at a decent level. You want to be able to take that load on one leg and be able to handle that. And then hopping forward, which is probably the highest loading rate on the tendon. So it's really important we try and tick those boxes. That's an important link between rehab and getting back running. And it's also important, I suppose, to address the kinetic chain. So, you know, being able to squat or deadlift, do some sort of a whole body exercise. And again, not everyone's going to start with a heavy squat. This is kind of your more well-trained athletes who are experienced, you know, be able to squat 1.5 times body weight for a few reps. If you are going that heavy, again, just have your safety mechanisms in place, have your safety pins out, be comfortable sitting back on the heel. Should always finish a squat if you're doing, say, 4 to 6 reps, be able to finish their set with the ability to do 2 more reps if you had to. But for someone who's not experienced in the gym, they can just do a simple goblet squat. If they're comfortable sitting back on the heels, great. So I'm just going to let this play. And push up fast. Again, the bottom of the squat, we want torso angle and shin angle to be parallel or as close as possible. Sitting back on the heels, knees not coming too far in front of the toes. And that's just a nice way to spread the load around the lower limbs. Make sure that glutes and hamstrings are doing the fair share as well as the quads. And if someone is not comfortable sitting back on the heels, they can use a box or a chair. So put that, you can see the stool behind, they can sit back on that and aim to tip the chair and then back up again. And then also maybe some single leg strength as well is important. So doing step ups, lunges, or even an example here of a Bulgarian split squat. Load one leg at a time. And again, just at the bottom of the bottom position, make sure we got good alignment. Let this play. So control going down. If I just pause it there, shin angle, torso should be fairly parallel. Back knee should be sort of in line with the hips and shoulders. So again, just getting your stance length right and be explosive coming up. Okay, so again, aside from injury, there are, you know, obviously performance benefits from strength training, and especially if you haven't got a massive background of strength training, if you introduce it at the right time in the right way, you know, there is a carryover to performance. And one of the most common ways of measuring, I suppose, a response to strength training is measuring someone's running economy, which is how efficient you are at utilizing oxygen at a certain speed. So, you know, plyometric training has been shown to have, you know, over, say, 12 to 14 weeks has been shown to have a 4% improvement in running economy. Heavy and explosive strength training, so some of the examples I gave in the previous slide of doing heavy squats or doing something explosive improves running economy and time trial performance in 2 studies. And again, there's plenty more out there. And particularly the calf. I know I keep going on with the calf and the tendon, but doing increasing calf strength and improving the elastic properties of the tendon has also been shown to have a 4% improvement in running economy. So to put that into context, you know, we know that some of those modern advanced running shoes with the special foam and the carbon fiber plates, on average, across the people who have been studied, has been shown to have a 4% improvement in running economy. You know, people will spend 300 euros or thereabouts to try and get those benefits. But you know, again, if you're doing strength work as well, you're kind of covering all bases, and you may get, doesn't mean guarantee that you get 4% improvement in running economy, but you may get some benefits if you haven't got a huge baseline already, if it's done in the right way and factored into your week carefully. So just a couple of sum up slides here. It's important to, you know, if someone's rehabbing, it's important to build tissue capacity, build strength, and then, you know, have a phase of building power and reactive strength with our plyometrics. Build the training capacity needed for your event. So if you're, you know, a middle to long distance runner, again, being able to do back into your long runs and, you know, an appropriate number of interval or tempo running sessions before you're race ready. So again, it's important to work through those steps in that sequence, depending on the injury it is, and that kind of model can be applied to most injuries. So to sum up, how to be a robust athlete or to build that robustness, you know, we want to try and give the body a chance to adapt. So a gradual increase in training load, not trying to accumulate too much too soon. And especially training for a marathon, you know, people can often go into like a 3 or 4 month marathon training block off a low baseline, and they accumulate a lot in 2 or 3 months, and that elevates the injury risk. Not allowing sufficient recovery time between sessions. So if you're trying to squeeze in an interval session on a Tuesday and a Thursday and a long run on a Saturday, If you've got a busy week, that might be enough time to recover. So you may need to, I suppose, adjust it to your needs. Having a strength training program, and again, strong people will still get injured. You know, it doesn't give you license to be careless at other things, but if you're doing a strength training program that's appropriate to your level of training and your needs, along with doing everything else right, it's certainly going to go a long way towards making you robust and build the tissue capacity needed and to be able to weather the storms in terms of training and load increases and so on. Quality of sleep, and again, that's I suppose if you look at the one thing that's going to influence recovery most is quality of sleep. That's where most of the repair happens. Nutrition as well, so again, getting good fuel in at the right time, and making sure you're hitting your calorie needs on a day where you've got high energy expenditure. And also, if you're trying to build tissue capacity, making sure you're hitting your protein needs. And also allowing or managing non-training stressors and not overlooking that. And I suppose the most important thing is consistency. So the more consistent you are training with minimal gaps in your training weeks, you know, the more robust you will be. And I suppose from a performance point of view and an injury point of view, that's going to stand to you. So hope you found it useful. Happy to take some questions.
Thank you. Really interesting talk and a lot of questions coming in. Now, a lot of people are asking about exercise for strengthening the calf muscles. So maybe just talk a little bit about that, when to do them, how often, can you do too many?
Yeah, no, I just seen there's a few questions that kind of more or less ask the same thing. So I suppose take that topic, I suppose, as a whole, and I touched on the presentation. You saw some examples of exercises there. As I said, the calf muscles are big players in terms of, I suppose, propelling you when you're running. They're also quite an injury-prone muscle group because they can be weak and underdeveloped if we don't we take up running late and go in at a low base of conditioning. You know, they can get overloaded, and it is important to address them in your strength training program, and particularly if you're injury-prone to any kind of lower leg injury. So I don't like the idea of doing calf stuff every day. So I like interval training, 2 sessions a week of reasonable intensity where you feel like you're working the calves, but give them a chance to recover. The challenge for those who might be doing an autumn marathon, say in Dublin Marathon next month or anything else over the winter months, you're at a stage where you're probably in a lot of higher volume training. Your body's under enough stress as it is. So it is a bit of a balancing act trying to do the right amount at this moment in time without being at risk of overdoing things. So I would say for those people, maybe just try and give it twice a week. 4 sets of 10 reps each side. At a weight, you could probably do 2 more reps in the set if you had to. So as I say, 2 reps in reserve, and just let them recover, and just, you know, microdose it in around your training week. That it doesn't compromise your recovery too much.
Okay, thank you. There's a few questions then. How often do you find REDS is a factor in running injuries, and what do you advise?
Yeah, so REDS, for those who aren't familiar with it, is relative energy deficiency syndrome. So basically, under fueling. And you know, there could be other factors there as well. It's commonly seen in female athletes, and particularly younger female athletes of late adolescence moving into early sort of senior age, early adulthood. But there can be other psychosocial factors involved there as well, like that can be driving it. You know, being kind of body aware and focusing on image, and maybe thinking that the lighter the better in terms of running performance. Or people can be just a little bit oblivious to their fueling needs and maybe underestimate it with the right intentions, and maybe just mightn't understand or realize how much they actually need. So it is quite common for different reasons. For those who have more sort of psychosocial factors driving it, they probably need a bit of psychology input. So in those cases, we would involve a sports psychologist just to help them maybe look at things a little bit differently. Definitely nutrition input. Have a nutritionist to, you know, devise a nutrition program to tailor their needs and address their deficiencies. And again, we see it oftentimes in male athletes, and it's just purely because they don't actually realize that they're undercutting their calorie requirements during the day as well, and particularly when you're training for a marathon. So it's a big driver for a lot of bone stress injuries, because bones need energy as well as other body parts. And if bones are left depleted for too long, their metabolism slows down and you're not able to replenish on demand. And then you're in that sort of spectrum of a bone stress injury, worst case scenario, a stress fracture.
Okay, thank you. Now, this has come up a few times as well. So we've just one question we're going to ask you. What do you think about carbon plates?
Yeah, I mean, look, everyone's wearing them. Everyone responds differently to them. So it's very hard to give a sweeping answer to cover everybody, because you don't really know how you respond unless you try them. Nobody has the technology to actually assess your foot type properly and how you might respond to the shoes. You know, initially, like Nike had the I suppose first mover advantage that was their sort of IP, and now other companies do this similar thing. So there's different options out there. All the main running shoe companies provide this footwear technology. So it is a little bit of trial and error. You know, some people have asked like about the risk of injury. There are risks for some people. You know, while the foam can help a little bit with preserving, I suppose, the demands of the muscles during running, but they can also adjust your foot mechanics, cause a bit more stress on the metatarsals. And again, if you're predisposed to bone stress injury, that can be a problem. So yeah, I mean, for me, I prefer to save them, and it's just me personally. I prefer to save them for race day, save that feel-good factor for a race, and try to wear my normal shoes and my normal runs. Maybe the odd time do a little bit of a familiarization session in them, in the lead up to a big event, but not too often. Some people would just wear them on their long runs to try and protect them, and again, that might work for some people, maybe not so much for others. So it's a little bit of trial and error, and if you have had a bad experience with them before by wearing them chronically in training, I'd maybe suggest just be a bit more sparing with them. Find a pair of shoes that you're comfortable with, wear them in your day-to-day runs, and save the carbon fiber and foam cushion shoes for race day.
Okay, thank you. This is someone with a specific question with a bulging disc, L4, L5, low back pain, sciatica. Physios helped with sciatica release, but advised to get a steroid injection or the disc scaled back as there's nothing they could do for my back. Do you have any recommendations for building lumbar resistance?
Yeah, I mean, any of your big lifts. I mean, just again, I've had personal experience with this injury. I had quite a nasty disc bulge at both L4, L5 and L5, S1. So I had radiculopathy, and that was back about 3.5 years ago. Had a lot of loss of strength and development of numbness down the lower leg. So it took us, I was out for several weeks. In the end, I got a nerve root injection and got my, I suppose, function back after about 10 days. But again, different people respond in different ways. Some people can recover naturally over time. And I suppose in worst case scenario, some people would be recommended to go and get a surgical opinion with a view to getting a microdiscectomy. But from a strength point of view, there's lots you can do. I mean, it is important to keep moving. And if you're able to run at the moment and the symptoms allow you to run, and there's low level symptoms like I have, and I still have to manage it, you can manage it fairly well. So any of your big lifts, like squats, deadlifts, just make sure you're moving well first and foremost and feel slightly challenged. Doing things like hip thrusts as well. I gave an example of a squat or even a goblet squat in the video there in my webinar. But there's lots you can do. So definitely work with your, physio and if you can, an S&C coach. If your physio feels that they've taken as far as they can, an S&C coach. And if you get into trouble again, it's just worth seeing a sports medicine doctor or even a spinal consultant just to get their opinion on it and see what other interventions they might suggest if it comes to that.
Yeah, lovely. Thank you. Again, what can I do if consistent tight calves? There's a calf one again then. We've kind of answered those ones, but they seem to be causing knee issues. So I suppose with knee issues, what can people do?
Yeah, I mean, when your calf muscles weaken and when your ankle area weakens and fatigues, you're trying to maintain the same output, there's a bit more demand at the knee. So again, when I'm dealing with knee injuries, we always look at above and below the knee. So, above the knee, looking at quads, hamstrings, and glute strength, and also below the knee, looking at your calf muscles. So, definitely like the previous question, try and keep some, low volume, high intensity calf strength work in there, maybe twice a week if you can. Also not neglect other parts of the body. Make sure you're strong further up the chain as well. Maybe doing some sort of hopping exercise. I think I gave some examples there in the webinar. Just to improve how you coordinate. And I just try to make sure your running training week is fairly well balanced and structured and meets your needs, and doesn't feel like too much of a stretch when you fit everything in. If it means dialing back and maybe replacing one of your easier runs with a cross-training session on an elliptical trainer or a spin bike, that might be the best balance in order to keep you training and give you more time to recover.
Okay, good. Recommended recovery time after a long run, 15 to 20 miles while training for the marathon. How many rest days are recommended during a week?
It depends on your, I suppose, training background and training age. So if you're quite experienced, I still think it's important to have at least protect 1 day a week for recovery. That could be a complete rest day or something that's light and easy, or something maybe that's not, it could be an easy run, or it could be just an easy session on the cross trainer, going for a swim or something like that. Definitely have 1 day of the week, and some people might need 2. But if you've done a long run, I certainly would be trying to do a hard session within 2 to 3 days afterwards. So if your long run's on a Sunday, maybe, the earliest Tuesday, and even if you're training for a marathon, I push it out to Wednesday. I mean, when you're training for a marathon, at this stage, I'll be treating the long run like a key session, and then trying to fit in one midweek sort of interval or tempo type session that's geared towards marathon, your marathon pace. Focus your week around those 2 sessions. Make sure your recovery is adequate in between.
Yeah. Do you rate reformer Pilates as a method of rehab or injury prevention?
It would be down the priority list. Again, it has its benefits, and some people do like it. And again, I wouldn't argue with that. But in terms of developing strength and everything else, it doesn't compare with plyometrics, with doing good lifts really well. Where you're on your feet and vertical and overcoming gravity. As I said, I would see reformer Pilates as an add-on, if you've got time and can fit it in, but it wouldn't be done in place of a good gym-based strength training program.
Great, thank you. Someone's asking, how can you stop impingement around the hip? Happens the day after running. Is there a way of managing this?
Yeah, so let's get the diagnosis clear as what is actually causing impingement. There's two types, but if you're able to get through your run and it's not bothering you during the run and it's only the day after, that's actually not too bad. You can manage that. In that case, I would just keep on top of your hip strength work. Your sort of lateral or side hip muscles that abduct and externally rotate the hip, and the back of the hip muscles in the front of the hip. So just make sure that the ball and socket can move fluently, because all the muscles around the hip area act like a sling. Maybe a little bit of mobility work, but I wouldn't push it too much. Again, everyone's hip morphology is different, so some people just don't have the bony anatomy to handle being forced into mobile positions that they're not just quite able to, especially if they're a little bit older. So I'm always careful with that. And then often people who are hypermobile can have poor stability, poor control, and the hip joint can sort of impinge a little bit earlier as well. So again, it's hard to give a blanket answer, but the fact that you're actually able to run and it's only the day after, and as long as it recovers again the day after that, you could probably work with that, especially if you're training for a marathon.
Okay. Somebody has fissures in the cartilage of their knees. They're age 42. They're still running. Is there anything can be done to improve the condition?
Strength work, and again, if you keep moving, cartilage does like exercise; it likes impact. When you the worst thing you do is actually stop and do nothing. So definitely keep moving. And then again, if your symptoms allow and doesn't trouble you too much on your runs, keep it going, but do keep on top of your strength work, particularly around the quads and hamstrings. And then some coordination work with some plyometrics and big lifts. So again, a bit of I suppose similar to most other injuries that we kind of touched on there as well. Definitely keep on top of your strength work.
Yeah. This is probably the last one now. So very informative presentation, Colin. Thanks very much. I hear mixed reviews on stretching before and after runs. Some say it's bad, some say it's essential.
Wouldn't say it's essential. Before a run, it's whatever makes you feel good when you're running. Sometimes doing a lot of long static stretching isn't great. Some evidence that it can temporarily reduce your sort of power for up to an hour or so afterwards. Again, it mightn't affect other people either, so it's very much an individual thing. I would prefer doing some dynamic stuff beforehand, maybe some dynamic mobility work, just moving into positions that challenge your mobility a little bit, while also making sure you're able to coordinate and be balanced, and use the muscles around the ankles and hips and so on. After run, I wouldn't get too pushed about it. If you do need to improve flexibility for some reason, I would keep it as a standalone session, because after run, and especially after a hard session or after a long run, your muscles are going to be fairly beat up, and stretching is certainly not going to speed up recovery. You might feel good for a while afterwards, but it's not going to actually change much in terms of flexibility. So if you are going to do it, I would do it separate when you're a bit more fresh, if you do have any flexibility goals, whatever that reason might be.
Okay, thank you. Thanks for joining us tonight, and thanks to anybody who's joined us tonight as well. If you need any further information or you want to make an appointment, there are numbers there that you can use. Also, we will be sending an evaluation out, so if you can give us your any ideas for further talks or what you thought about this talk, that will help us set talks in the future as well. So thanks everybody for joining us. Thanks, Colin, and good luck to anyone who's in the marathon in a few weeks. Thank you.